the person of Dr. Abby Ann Lynch. But before I introduce our speaker, I'd like to continue our custom of recalling at the first session the origin and purpose of this lecture series. And I'd like to call on Sister Maria Sutherland, who usually does this for us, by the way, to talk to us about, in a few words, the purpose and the origin of the lecture series. Sister Maria.
When I came in, one of the sisters here said, "Good evening, and I welcome you to these lectures." So I invited her to do it if she'd like, but she declined. So good evening, and welcome to this annual Elizabeth Seton lecture series, just to prove she was right. This series began in 1978, when the Sisters of Charity of the Halifax province, responding to a proposal made by the Sisters of Charity who were on faculty here at Mount St. Vincent University, established an endowment fund for the purpose of providing this annual lecture series with the general theme of Christian presence in the world, past, present, and future. We believed that these lectures would be a tangible contribution toward that environment characterized by a Catholic tradition, which is described in the Mount's mission statement. We believed it would also be a contribution toward expressing publicly Mount St. Vincent's commitment to understanding the truth, to intellectual vigor and social responsibility. Many of you who have attended the Elizabeth Seton lectures over the years since 1978 can attest to their quality and their fidelity to this original vision. We have named these lectures for Elizabeth Ann Seton, foundress of the Sisters of Charity in North America. I'm sure tonight's topic would be of special interest to her. Mother Seton, as she is known to us, was no stranger to family illness and death, and to the faith and courage they demand of us. She knew from personal experience the pain of accompanying loved ones to death. She was only 29 when her husband died, leaving her with 5 children and very few resources. She watched 2 young sisters-in-law who had followed her into the Catholic Church, she was a convert, and into her new community, die only 4 months apart in December 1809 and April 1810. 2 years later, in 1812, she knelt at the deathbed of her oldest daughter, Anna Maria, whom she called Nina, then 16 years old. And her youngest child, Rebecca, was only 14 when death came. So while Elizabeth would not have had to make the choices that Dr. Lynch will speak of tonight, she certainly felt the pain and the grief that these losses occasioned. When Anna Maria died, Mother Seton described her grief. To one friend she wrote, "For 3 months after Nina was taken, I was so often expecting to lose my senses, and my head was so disordered, that unless for the daily duties always before me, I did not know much what I did or what I left undone." And to another friend, "The remembrance of my lovely one now forces itself on me in every moment." Her singular modesty and grace of action, the lifting of her eyes from the ground to cast the rays of her very soul into mine. The style, of course, is much different from the style of wording we'd use now, but the sentiment is so much the same. And that was often her only expression of her desires or wishes. And now I am so happy to think I never contradicted any of them. And her biographers tell us that it was a severe and long-lasting grief, and she would talk of Nina until she died, for no mother ever forgets her child. Elizabeth's strength in these sorrows came from her reliance on God and her love of God's will. And she found resignation, for the human grieving of the heart and resignation in the suffering are not contradictory. They are 2 very different things. Elizabeth herself knew how to make the distinction, and she writes, "The separation from my angel has left so new and deep an impression on my mind that if I was not obliged to live in these dear ones, her remaining children, I should unconsciously die in her. Unconsciously, for never by a free act of the mind will I regret his will. Mount St. Vincent commits itself to the continuing moral development of those sharing in its life. Elizabeth Seton, faced with a decision, never asked, "Is it easy?" She only asked, "Is it right?" And once convinced of the rightness of her choice, she found peace in doing God's will. The topic of this year's series, Healthcare Decision-Making for Others, will surely contribute in a very direct way to our ability to live in this moral way. I would like once again to express appreciation to the Religious Studies Department of the Mount. They have accepted the responsibility for administering this lecture series and have continued to engage stimulating speakers to inform and challenge us on topics of current interest and urgency. And tonight's lecture, I'm sure, will be no exception. And so for the Sisters of Charity, I welcome you again to the Elizabeth Seton Lectures.
Thank you, Sister Maria. Since the inauguration of the Elizabeth Seton Lectures back in 1978, we've had many prominent speakers as our guests. This year, of course, is no exception. We continue that tradition with Dr. Abby Ann Lynch. She is currently the director of the Bioethics Department of the Hospital for Sick Children in Toronto. She has held teaching positions at George Brown College, the University of Toronto, the University of Western Ontario, McMaster University, and Memorial University. That she has taught in their faculties of medicine, dentistry, nursing, social work, applied health, and arts and science gives us an indication of the diversity of fields to which her talents have applied. From 1986 to 1990, she was the director of the Westminster Institute for Ethics and Human Values in London, Ontario. She holds numerous ongoing ethics consultancy appointments, particularly in the medical field. She is the president of the Canadian Society for Bioethics, a prolific writer and lecturer, and recipient of numerous awards. Dr. Lynch has been invited or appointed to many international committees and conferences. In this series of lectures, which begins this evening and continues tomorrow morning at 10 o'clock and tomorrow afternoon at 2, Dr. Lynch will speak to us about a fundamental aspect of healthcare, that is, healthcare decision-making for others. It is with great pleasure that we welcome her to Mount St. Vincent University, Dr. Abby Ann Lynch.
Thank you very much for your very gracious introduction and for the warm welcome from the sisters, and certainly the warm welcome from this audience. It's a great pleasure to be here. I hadn't realized that I was the 13th speaker, and as I came on the plane today, I sat in the 13th row, so 13 seems to be a very lucky number for me. I'm particularly pleased to be here to talk about this whole question of autonomy and healthcare choices. A word first about that theme for the three presentations here. My remarks are going to be confined to a very general area, the area of healthcare ethics. It's a field which I hope is sufficiently current and challenging to interest you people who've come this evening. Within that field, I'd like to address a topic which many identify as the most fundamental. That is the notion of autonomy, of self-direction, as it pertains to the patient's choosing or refusing of proposed healthcare interventions. There's wide discussion about the meaning and the grounding of autonomy. Some speak about it as respect for others. Some speak about it as responding to others as one would wish to be responded to. Some find it in a notion of religious practice. I'm going to set that particular discussion aside to get to the focus of these papers, and that is patient choice in the healthcare context. We live in an era of rights. Rights for women, rights for animals, rights for workers, rights for students, rights for the trees, rights for the environment, and not least of all, rights for patients. Among the rights which are demanded by patient rights groups, and a right which is enshrined in Canadian law, is the right to consent to or to refuse treatment. This is not seen as a right to choose the treatment one wishes, but rather as the right to say yes or no to what is offered as the best judgment of the practitioner. In Canada, as you know, and unlike the situation south of the border, we also have the right of access to hospital and to medical diagnosis and to therapy. That's a right for each Canadian, which makes it possible to choose or to refuse what the practitioner suggests. The patient's right to consent or to refuse thus has a meaning in Canada which far exceeds the scope of such experience in the United States. In fact, however, not all Canadian patients can choose or refuse suggested treatment. Think for a moment of the newborn child who cannot express any preference. Think of the person who's cognitively impaired from birth, the individual who is developmentally delayed so far as intellectual functioning is concerned. Think of the individual who has become cognitively impaired, whether by accident or by disease. Think of individuals who may have intermittent ability to make decisions, for example, those with mental illness. Think of those whose cognitive abilities are steadily declining so that choice and refusal are rapidly becoming meaningless, for example, those with progressive senile dementia. We appear to have in our community then two groups of people: those who can decide, and thus it might be argued who have a right to decide, and those who are unable to decide, and thus who have no right to decide and must rely on someone else, perhaps on one of us, to make decisions about healthcare interventions on their behalf. In philosophical terms, then, the situation is not unlike that of the Cartesian, who says, "I think, therefore I am." Here, I can choose, and therefore I count. My concern is with this second group, the ones who have intellectual impairment, who are ruled aside by way of the yardstick of autonomy. I'm concerned as to the method by which others choose for them. I'm concerned about who makes choices for them. I'm concerned as to what choices are made on their behalf. And I'm particularly concerned about a line of argument which is now being proposed with some vigor in my own discipline, that is philosophy. According to this argument, those who are unable to choose are now to be called non-persons. A corollary of this could be that as regards decisions to be made about the use of resources, for example, the status of non-person might render such an individual as somehow socially diminished, with a lesser priority than the status accorded a person, that is, one who is able to choose. To illustrate my concern, consider this quote from a current and well-regarded book. It's called Deciding for Others. It's on page 119. A quote, "The distinction between persons and non-persons marks a fundamental difference between two kinds of moral status. Those non-persons who have the capacity for pain and pleasure have some rights, although these rights are limited due to the inferior moral status of non-persons. A large question that I'll put aside for now asks, from what source do these rights come, and on what basis? Well, one question before society in a time of limited healthcare resources concerns the decision as to who shall and who shall not have access to such resources. Whatever the cutoff criterion is to be, there is one yardstick which is just now in place, and it may well be used for that kind of judgment as the previous quotation indicates. That yardstick is autonomy, the ability to decide. And my question to you, if this is to be the yardstick, then what is going to happen to those who are ruled out? Such a question, I think, will have particular relevance in this faith community, with its well-established preferential option of caring for the poor, the sick, those who are in need, and those who have been marginalized in society. Have those of us who share in this faith some particular obligation within the vocation Christian to speak out particularly for those who could be identified as non-persons, that is, those who may be impoverished, intellectually speaking, or those whom we have somehow made impoverished because we perceive their limited cognitive ability as a limitation of person. Does the Christian imperative extend to persons only? And what do Christians owe to those who have been identified as non-persons by what I've called the tyranny of autonomy? My remarks over these 3 lectures are to be understood in the context of those questions. And so to the first one about children and choices. How will healthcare decisions be made when the decisions concern the treatment or the non-treatment of very young children? The general question raises queries about several aspects of such a decision-making process. Who's to be involved? What standards will be used? What reasoning is to prevail? Inasmuch as children cannot speak for themselves, these are significant questions. How so? When we speak about children, we're talking about our own community's future. If we are committed to that future, then children and what happens to them are important to us. Moreover, children are related to us in a particular family way. They are precious, they are loved. We have special responsibility for them as sisters, brothers, parents, relatives. More selfishly, children will be the ones to care for us in older age. In our own self-interest, we should protect our future by protecting them. And finally, even as unrelated to us, children are part of the human race. In our religious and our cultural traditions, children share our humanness, which means that they have an origin and a destiny which is profoundly spiritual, like our own. They have a dignity of their own which is not given by us, but one which calls for our recognition and respect. First then, who decides health care for children? By law, for children who are under the age of maturity, those decisions are to be made by their parents. This seems an eminently reasonable position. Parents know their children best. Ideally, they love their children. And parents are the ones who are responsible for children's protection and nurture. In making such healthcare decisions, parents are aided by healthcare practitioners, by physicians, nurses, social workers. These professionally trained individuals are educated to know the science and the art of healing. They can identify the child's disease or illness, They can prescribe what must be done to bring about the child's cure, or to establish the way of coping with the child's chronic condition. They know what is too much and too little in the care of sick children and of my child. Even with all this assistance, however, parents remain the decision makers, obliged to look after their child's health, just as they are obliged to attend to their child's education and to ensure their child's socialization. In the best circumstances, decisions about any child's health care, then, are informed for the parents by the knowledge and advice of the healthcare practitioners. They are made by way of a dialogue among physician and parents as partners. In the end, however, such decisions are to be made by the child's parents. The second question: what standards are parents to use in making such decisions? Current law and the inner dynamics of the parent-child relationship say that the child's best interests shall prevail. With that concept stated, the simple and obvious becomes very complex indeed. What does best interest mean, and whose interpretation of it shall count? I'd like to tell you 4 stories about children. The first is the case of Kayla, and some of you may have seen the TV production about Kayla on the Roy Bonesteel show on the CBC. Kayla was a native Canadian child. At the age of 2, Kayla was diagnosed by the physicians as having a serious illness which could be cured only by having her receive a liver transplant. Her parents didn't want that treatment for Kayla. In their native spiritual view of the oneness of nature and Kayla's place in it, they felt that a transplanted organ would be a foreign substance within her. Further, they believed that with such a transplant, the medicine Kayla would have to take each day to keep it in place, so as not to reject it, would make her subject to many other infections. And they thought that because of that needed medicine, she would also be more likely to contract other diseases, for example, cancer. There was question among some of the physicians concerned with Kayla as to whether her parents, in making that decision, were really acting in Kayla's best interests. Perhaps her parents, in taking their stance, were really neglecting or abusing her. Liver transplant, after all, is the treatment of choice for Kayla's condition. And there were estimated very good results if Kayla were to receive that procedure. Ultimately, the Children's Aid, society's mechanism for protecting children when parents seem unable to do so, became involved. Because of their fear that society would take Kayla away from them, her parents went into hiding. And finally, the case of Kayla came before a children's court in Saskatchewan. The judge there determined that Kayla's best interest would be served by following her parents' wishes. Kayla did not receive the liver transplant, and she died shortly afterwards. In her case, the best interest of the child was identified as non-life. Continued life with a liver transplant was rejected as not in Kayla's best interest. A second story about a child I know a little better than Kayla. Susan is also 2 years old. She suffers from an ailment which may make her blind unless it is investigated and treatment given as required. Susan also has a sickness for which a blood transfusion could be of assistance. She'll not now die without the transfusion, but it's likely that she'll need the transfusion very shortly if she will survive. So as to carry out the examination of Susan's eyes, the physician must give Susan a general anesthetic. The examination proposed is more easily and quickly done when Susan is unconscious. And the physicians want to be prepared should Susan's condition suddenly change or deteriorate while she is under anesthetic. They ask her parents to give permission for a transfusion should it be needed, and the parents refuse. In their religious view, any blood given to Susan would be a foreign substance. In particular, transfusion is prohibited according to their religious practice. So Susan's case, too, went to the Children's Court. And the judge ordered the eye examination for Susan and said it was to be done under anesthesia with blood available and used as required. Here, the child's best interests were seen as requiring care of vision and continuance of life by way of transfusion. The interpretation of Susan's best interests, as given by her parents, was set aside. With these two cases, then, it's clear that best interest need not always mean the preservation of life. Consider one more case, this time of a younger child who is called Baby Andrew. This child was treated in a newborn intensive care unit for an acute breathing problem. His story is related in a book which is called The Long Dying of Baby Andrew, and it's available to be read by the public. It tells of several months of severe pain for Andrew, all of the months spent in the intensive care unit. During that time, he suffered several incidents of non-breathing, and as a result of the physician's attempt to use extraordinary means to care for him, he suffered several physical injuries. In the end, he died of the side effects of mechanical respiratory assistance, with numerous fractured and demineralized bones. In the later stages of his illness, Andrew was given all possible treatment despite his parents' objections, and they said that they felt this was not in his best interests. The case did not go to court, and Andrew died at the age of 5 months. It appears that those who determined Andrew's best interests here were physicians, not his parents. We have then 3 instances in which best interests of the child are identified as the correct standard for making decisions in the care of children. These instances seem to point in several different directions. In the Kayla decision, life is not the highest value, and it's not equated with best interest. In the case of Susan, vision and preservation of life are the highest values, and they are equated with best interest. In the case of Andrew, the attempt to save life and perhaps to expand medical knowledge seem to be identified with the baby's best interest. Now, to be fair, these are not your everyday cases. Thousands of children receive medical treatment in any given week. They survive and they thrive thanks to the dedication of healthcare practitioners. Their care does not involve the heroics just described, but the cases described do make us reflect. What does best interest mean? Whether it's applied by the physician, by the parents, or by the court. What standard do those of us who are competent to decide actually use in deciding for those who are incompetent when the matter at hand is a decision regarding the treatment or the non-treatment of children? And even if we could determine that there was a single standard, how could we be so certain that it would be applied reasonably and consistently in the care of each of the children who requires decision about treatment or non-treatment? Just one more story. And this is the case of Baby Doe, and I'll call him Baby Doe number 1, because there are several Baby Does, which is the name given in the United States when a child's case is taken to court. This child, who's also known as the John Hopkins baby, was born with an intestinal blockage such that the baby could not digest food properly. The usual treatment for such a child would be surgery to correct the problem. The surgery is easily done, or so I'm told by the surgeons. There are usually no complications. However, baby Doe was also identified as having an extra chromosome. In his case, it meant that he had Down syndrome. And it meant that this genetic anomaly would express itself as he grew older in some degree of mental retardation. How serious that mental retardation would be was not clear. In any case, baby Doe's parents refused the surgery when it was proposed by the physician. And baby Doe died of starvation and dehydration some weeks later. His case was not reported to the Children's Aid in that part of the United States. Those deciding about baby Doe were his parents and the physician only. Presuming the decision to allow him to die, or more accurately, that his death would be assured, presuming that decision was made in baby Doe's best interests, what are we to think of that decision? That mental retardation, whatever its degree, is worse than death? That a foster home placement is worse than death? Or was it that the decision makers in this case were using a quite different ethical standard, that of the best interests of the family? Certainly, the parents were quoted as commenting that the care of a mentally retarded child might have a negative impact on their own lives and that of their other child. With consideration of this case, we must then add to the list of possible standards for decision-making in the care of children consideration of parental obligation to the family, that is, to parents and to other children, not just the child who is sick. This standard, one which requires attention to overall parental responsibility for all children in a family, could be interpreted in two ways. First, that parents must treat all their children fairly, not singling out anyone as more favored than the other. It's not an unusual standard in everyday family life. As a parent, I try to give each child what the child needs to develop uniquely to maturity. I do it considering all other children in the family similarly. Thus, this particular child may have a talent for music and that one does not. And so I try to provide music lessons for the one child and not for both. I try to help the other one with skating lessons or support for the Little League baseball team. That's where his interest is. According to this standard, parents need not and ought not to treat children identically. They do have an obligation to treat them according to each child's best interest as well as they can. But there will be a limitation on working towards those best interests, since parents are required to treat all children in the family equitably, justly, similarly, but not identically, in terms of preventing harm and of providing nurture. And so the question here, if non-life was chosen for baby Doe on the grounds of parental or familial interest, was that choice right in terms of the first sense of familial interest? Or is it that non-continued life for baby Doe is better for the happiness or the interest of everyone else in the family? A second interpretation of that standard of family interests, that is, that the majority counts. Can I, ethically speaking, refuse treatment for one child so that I'll have more time, more energy for the other children? Or, by the other standard, must life for baby Doe be seen as non-negotiable and the family somehow suffer in consequence? Of course, unless I really believe that living with mental retardation is worse than death, I do have another option. I could allow baby Doe to have surgery and then have baby Doe live with foster parents. But that resolution of the problem seems not to have been considered in this case. Now, this second ethical standard, to treat children in accordance with majority family interests and not according to the best interests of the individual child, has been rejected by many individuals and groups, specifically by the Canadian Pediatric Association. In their document, the authors write, quote, "The primary concern of physicians caring for children must be the best interests of the individual child. No other interests can override those of the child, whether they be family stability or well-being or the well-being of other caretakers," end of quote. The standard of the majority family well-being as prior to the place of individual child well-being has also been rejected in setting out the grounding for Canadian transplant law. Thus, in Canada, no very young child in a family can be used as an organ donor for another child, so far as transplant is concerned. The best interest of any one very young child is not to be sacrificed for the best interest of another. And thus, if I have a son who is dying and requires a kidney to save his life, I cannot authorize the use of his young sister, who's under the age of majority, as a donor, even if she is a suitable donor and the procedure will not kill her. The ethical standard used in framing that law prohibits possible harm to one individual child for the sake of another. My son's best interest cannot require me to go so far as to sacrifice the possible health of any other child of my own. Majority family interests, the interests of one child against another child, are not to be put into the equation here. I do what I can for the sick child, hoping to find an adult donor, for example, but my sense of family integrity will not override my responsibility for the well-being of each individual child so far as I can manage it. If the family suffers a loss in my son's death, that may not be in the family's interest or his. Still, no one is to be sacrificed for the other. Individual integrity, not family integrity, prevails. And yet, we find this difficult. Somehow, we seem to say we have to take account of the family's needs, as well as the individuals within it. We say there must be some way to do both. Given these examples, it is evident that the ethical difficulties for those making decisions regarding the treatment of very sick, very young children are very real. While best interest of the child appears to be more immediately attractive as ethical guideline here, depending on its interpretation, that standard may also appear to be in conflict with the interests of the family majority, or, for example, the interests of medical education. Such a standard may also be in conflict when there are the interests of several children outside the family to consider. When each of many children requires the use of a particular service or treatment with one available transplantable heart, or the funding available for health care in the local community, which child's best interests will come first? Suppose, for example, that the question is this. A particular hospital not so far from here has a unit which cares for those children who have progressive physical impairment. There is no cure available for these children, and ultimately they will die. As it happens, that same hospital is asked by the community to expand its facility so as to care for other children in the community whose illness can be cured. Unfortunately, the hospital cannot care for both groups of children, those who are curable and those who are not, and there is no adequate care facility outside the hospital to care for either group. How is the hospital to respond? How is it to choose among the groups of children in need And how will any physician who's caring for 2 children decide which children or which child should have a scarce resource if the physician cannot provide that resource for each one? Should it be the child with the better chance, the curable child? Arguably, perhaps it should be the child who is not curable. Or perhaps it ought to be the child who got there first. Or maybe it should be the brightest. Or maybe it should be the poorest. These questions pose cases of competing best interests among several children outside the family. If the standard of best interests is to be adopted and used, how will it work when there are several children, each of them with best interests to consider? Further, even if it were clear how the interests of several children should be met when these interests are in conflict, and even if it were clear how the balance between children and parents' interest is to be reached, it's still not clear what best interests of a child includes. Preservation of life, freedom from pain, freedom from suffering? Will it require a supportive environment as necessary to development of the child's full potential? Will any one best interest be judged to be better by parents or society or the physician? In the face of these uncertainties, one thing is quite clear. We know certainly that decisions about young children's care will be made by adults. What we are uncertain about, bottom line, is the moral status to be accorded to children vis-a-vis the community. Many will argue that very young children are not morally equivalent to those of us who can think and choose until these children are at least 7 years old. Prior to that, because these children have so-called lesser moral status, we should keep them from harm, but always as protected pets, as somehow second class. If preserving them from harm or securing their best interests causes us harm or prevents realization of our interests, then, in this view, children will take lower status. As another variety of this argument, some might say that children who are older than 7, who have mental impairment or physical disability, could also be considered to have less moral status than children who have no discernible handicap. Again, this would create a second class within the second class. This latter position is rejected by those who hold that each individual human being is of similar worth and dignity, regardless of age or cognitive ability. In this perspective, children will be entitled to the same moral consideration we give to ourselves. No second class for them. But there is a third possible grouping here, and there are those who will argue that children should have more attention, greater primacy than adults, on the ground that children are fragile, developing human beings who are unable to survive without some special attention. Since their parents conceived them, their parents should be ready to sacrifice for them. In the absence of that kind of care, society should give them that priority, and then we become second class. In the context of these questions and of the cases raised, a very general issue emerges, and thus some concluding comments are required. Those of us who have the ability to think and to choose will be asked and required to make decisions for those who cannot do so. In the case of children, as noted, this task will fall first to parents, using the advice of others, and occasionally the task will fall to physicians and the courts. But increasingly, there will be pressure on parents, physicians, and courts to use as criteria those standards which will pay off, socially speaking. Those standards may not be seen as in the interests of the individual child, whatever those interests may be. We will be looking then for the benefit of the group, not necessarily for the benefit of the individual. This standard, if chosen by society, may not be the standard of the individual parent or the parents as a couple, and those who wish to be advocates for children. All of us thus have some serious reflecting to do. What do we mean by children's rights? How are the Convention on the Rights of the Child and the World Declaration on the Survival, Protection, and Development of Children to be interpreted in this society, not the third world, so as to give attention and to all of them right now? For all society, the questions asked here are our questions, and the answers provided must be ours, not those of the parliamentarians or the party leaders or the government bureaucrats. Our approach to this question, that is the question of the criteria we will use in deciding the treatment or non-treatment of very young children, will not be discovered by science or by intuition. These criteria will not be developed by means of a Gallup poll. On the contrary, together we will have to decide upon these criteria. We'll have to determine what they are based on our ability to reason and on our desire to create a truly human community and on our need to set limits in so doing. At that point, our own autonomy, our ability to think and to choose, may be seen as a burden to us. These are troubling decisions, we will say. Let someone else make the determinations required. Having that power of autonomy, that ability for self-determination, and the knowledge that we must use it as surrogates for others, we must use the power well. As parents and as teachers, we must help our own children, who would be parents, and our students to learn to use their power of autonomy well. We're not to function as tyrants by reason of our autonomy, that is, for our own good only, to the detriment of those without such autonomy, but rather our autonomy must be used for the benefit of those for whom we must choose as well as ourselves. If this were a matter of individual decision-making for each of us, it would be sufficiently difficult, but we would probably figure it out. But such standards must be set and observed by the community at large. What we're calling for, then, is a social ethic in the matter of caring for children. That particular achievement requires far more effort. In that work, for each of us, for all of us, there is much careful, prudent, and courageous thinking, discussing, and negotiating ahead. In my view, we must start on that journey right now, before it's too late. Thank you.
Dr. Lynch has agreed to respond to your questions and comments that you might wish to make. I'd like you to note that there's a microphone in the center aisle there for your use to make sure that you can be heard. Dr. Lynch?
It's refreshingly different from a philosophy class with my students, who'd be the first to kill the teacher. So.
Already experienced several very
Thank you very much for your question. It simply tells us one more time, in one way, just in a very general sense, that the more choices we have to make, as we do have today, with the possibilities, for instance, of neonatal intensive care and all the kinds of possibilities we didn't have when my children, too, were born, that we have so many more difficult choices to make. And at the same time that we have to make those, we find that they're being cut back in a way because of the sharing and the lowering of resources. But I guess the more general question that you're asking is, how is it that in terms of the kind of care that we expect for our children or our grandchildren at this point, how is it that we can make it personal, if that's what I take the flavor of your message to be? And I can only say that in a teaching hospital, which is where I am, that kind of personal care, which we may not see, speaking now as patient or grandparent of a patient, which we may not see, is really going on. It really is. There is agony behind the kind of, what shall we say, face which is put on it. And the reason that there's agony back there behind that face is because, indeed, these are young students who are learning. In many cases, they're very troubled by those decisions. That's what comes across my door as an ethics department. They are very frightened of making mistakes. There's a great deal of pressure on them to keep up the spirit and keep up the team kind of thing, so that they are very hard pressed about that. They're in the process of learning, so that would be one general thing, which I think we could agree could happen with people who are younger and in training and given responsibility and so on. The second is that with the great advances in science technology, the numbers of specialties have just blossomed, shall we say. And so we have so many people who are so expert who come to look at the very sick babies all the way from head to toe, and we may have 10 or 12 very serious specialists there looking at the heart and the kidney and the lungs and the liver and the brain and so on. And they're each doing their work so very accurately that in looking for precision, if you like, about the particular, they may not connect with the whole. But I would say that that is still the ideal for my students, and I think it's true for others. The contrast that we find perhaps with the super specialties and the subspecialties, which gives us the kind of excellence that we want in terms of diagnosis and prognosis, may make it very difficult for any one person to look after all of that, as we might say the family practitioner did, or the country doctor if we lived in that time. I think we may be in a position of saying that we're going to have to take some kind of balance. We can't have it all. I think we're going to have to help these young people to do it, and I think they're willing to learn. I'll give you just 2 anecdotes from my own experience. Some of the young physicians say, it's extremely difficult for me to break bad news, but it's so much easier when the parents help me out. And I say, that's a very interesting thing to say. Tell me more about that. And it seems that they are very frightened of making a mistake. They're afraid that they're not perfect. They're afraid of saying, this is bad, and I don't like to tell you it. And they almost want encouragement from us, and that seems to me to be a very good thing. It isn't what we expect, but it seems to me to be a very good thing, not only to help us, but to help them. I think the other thing to learn, that I have learned, because I haven't been there very long, is that these students have an excellent way of building a facade against the kind of pain and suffering and difficulty that they see every day. And they have to do that in a way to stay alive. Emotionally, they are wrenched every time. Now, that's not meant as an excuse. That's meant as saying that that's reality. So our perception may be that we are trying somehow to humanize medicine. I'd suggest that it's there, but it may be that we aren't communicating each with the other very well. That doesn't answer your problem. I'm just reflecting on what I've seen.
Dr. Lynch, I have a really specific question about the Taylor case that you mentioned. Yeah. Can you maybe go into a little bit more detail about how the judge reasoned, either philosophically or legally, that it was in the best interest of Taylor? Mm-hmm.
Basically, the judge's case, and it's unreported, unfortunately, but you can write to it. It's Battleford, Saskatchewan, and you could get it from the Children's Court there. It's not very long. It's been reported in a number of places. The judge starts by saying, this is the most agonizing decision that I've ever had to make. What happened in the case was that the child had the kinds of symptoms which identified the child as somebody who needed a liver transplant, according to the usual standard of practice. In hearing the case, the judge asked a number of physicians to give evidence. Several physicians said that in their view, of course this was the standard of practice, and that happened to be how the institute where I was became involved, because one of the people giving evidence came from our area. Several of the other physicians said, but we have to consider the long-range effects. We have to consider the possibility, for example, that with this drug that she'll have to take for the rest of her life to prevent rejection of the organ, she'll be open to numbers of other infections. So the ordinary infections that we might not get, she would be likely to get because of the drug that she takes. In addition to that, there are statistics that would show that for some patients anyway, there would be an increased susceptibility to certain other diseases, cancer being one of a very special kind, not generally. And so the judge, thinking very hard, because the judge's task there is to say, is this child being abused? Is this child being neglected? Is this child in the family? This judge said that he was very convinced by the testimony of the parents that they were doing this out of the best interest from Kayla. It wasn't a matter of getting rid of her or saying we don't need her or it's too much trouble for us. So building on the notion that there were some physicians who said we could understand it even though it is the standard of treatment, building on the parents' sincerity, building on his view that they were willing to even run away, which convinced him of their sincerity. Basically what he said was that seems to us to be the right thing to do. But I raised the question just because we easily say, how do we choose for children? Everybody says best interests. But when you begin to think about it, it's very hard to know what best interest is and whether you can isolate it and say it's always living or it's always having piano lessons or it's always going to school. Makes it very hard for society to decide. So.
Do you think it's possible at all for society to come to some consensus about best interest?
Yeah. I think it's going to have to do that, Professor Wheaton. I think it's going to have to do that in the sense that resources are getting more scarce. I think we're going to have to say something like, in the ordinary course of events, anyone who doesn't get this will somehow not be well treated. Now, we've done it very generally in terms, at least in my province, of speaking about the children's aid and saying, this is what abuse means, this is what neglect means, and so on and so forth. But when we have a tough time with medical resources, I really do believe we're going to have to think about, if it isn't going to be best interests, how are we going to deal with all of those children who need something? Maybe there's another standard out there. It's the same kind of question we'll be thinking about with the elderly people, with the mentally retarded people. What I would reject right off the bat is that children are second-class citizens. I don't think we can do that. Nor do I think we can say physically handicapped children are second. Beyond that, I think we're going to have to do it. If we don't, I suspect that financial cuts are going to push us to do it, and we won't have a plan. We won't have a rationale. And if we don't, we won't be deciding. So.
Dr. Lynch, I was in the States recently where a Catholic priest who's a moral theologian was giving us some ideas, and he was saying, if it's an ordinary treatment, do it. If it's extraordinary, you may or may not. If we apply it to the baby doe child, it just seemed to be an ordinary operation, and it should have been done, even though the child might have been somewhat retarded. But for a liver transplant, a kidney transplant, heart transplant, I think that would come under you may or may not, and with scarce resources, you better not. Unless somebody's very valuable, but just for ordinary people. I'm not that fussy now about heart transplants, liver transplants, kidney transplants, and all this sort of stuff.
I guess I'm kind of uneasy, Father, about ordinary and extraordinary people, but I'll leave that one aside. Trying to say, this is an ordinary treatment or this is an extraordinary treatment, we then are going to have to come to some standard of what makes it ordinary or extraordinary. Will it be that it's a lot more complicated, for instance? Will it be that it takes many more people to do it, lots more of healthcare resources? Will it be that it's extraordinary from the perspective of the physician or the parents? I think it's fair to say that many of the things that we consider to be ordinary right now were fairly extraordinary to open with. And so I find it hard. My sense is that we, if we are speaking in the Roman Catholic tradition and theological terms, my sense would be that we're going to start balancing benefit and burden. to the extent that the individual is the one who's going to do the measuring. The problem will be, of course, that for children, somebody else is going to have to do that. And of course, we're into the problem of what counts. What counts as burden, what counts as benefit. Yes?
I'm talking about legal background, and one of the things that I do is child advocacy. And certainly the problem of best interest is not, doesn't only come up in this area. It comes up, of course, in custody cases where, as in some of the more dramatic problems I had here, normally the standard doesn't have a whole lot of teeth. And I think that it's highlighted in those cases that you mentioned. But in doing some of the work that I do, I've kind of developed a notion that the best interest of the child is probably met if everyone who says they have the best interest of the child in mind are forced, in those situations where it's possible, to reach a consensus about what's best for the child. And therefore, in a recent case I had where you take the social worker who says they know that the best thing is not to have the child with either the mother or the father. In this case, the mother and father were separated and the department was given by the parent. They're both there saying the best thing is for this child to be with me, and they firmly believe that for all kinds of reasons. And there's a couple of other people involved. So, and as a child advocate, to attempt to get these people to, and if necessary, to hire a person with the mediation skills necessary to develop some basics on which, a decision can be made. Because although this might not be possible in every case, it seems to me in some of those cases you mentioned, for instance, the case where the parents decide not to continue the life of the child, well, it seems to me that would be an extraordinarily poor option for any parent. Regardless of what the other options are, that would be a very good one. And it seems to me that the family betterment notion is surely rooted on some concept of what is economically or feasible for that family or whatever, and that to explore some of the reasons why people feel they have to make that choice, and to bounce that around with other people who might have some other ways to meet that. Maybe a much cheaper and more effective way to solve one of those cases, because I think this either-or thinking, where coming from the medical perspective and the medical profession concept of the best interest and the parent concept is far too limited, because it seems to me that you're at the notion where if someone disagrees, that therefore the other has to be winner and loser, which is a fundamental problem in our society today. And in fact, to give it to the judge is another way of saying there has to be a winner and loser. And in fact, where I practice in Yukon, if any of those cases had gone before the judge, what would happen is that the public, the guardians, the official guardians, would appoint the child advocate himself to get involved and to start working with that group of people to try to help them out.
Thank you very much for your comment. I hope that everybody could hear what you were saying. It certainly does seem to me to be very extreme indeed to have to go before a judge to make such a decision. No problem. That's why I was trying hard to say that it's the parent's first responsibility. But the real difficulty comes when you see great disparity in what some parents will choose. So even if everybody could agree, for this child may be disadvantaged because everybody agreed, whereas this family, where everybody agreed, would have a different standard. And that's what worries me a little bit, if we don't have people who are going to try to make it as equitable as we can. I realize it can't be identical, but I agree totally with you. There shouldn't be winners and losers, particularly when the children can't speak.
The situation that I would describe is one where the child did cheat. It was a 12-year-old girl who had brain tumor, and who had received all of the technical expertise that was available in Halifax, which was considerable. The tumor recurred, and the question was whether she would have continued chemotherapy. And the child was included in the decision. And the decision of the family was that they would not continue with chemotherapy because the experience statistically in that situation was very negative. But the interesting thing is the way the community help the family take care of the child. The hospital made resources available. Social services, although the family did have some medical insurance, the social service representative in that county supplied all of the resources that were needed. Her death progressed over about 3 months, and for the last 6 weeks of that, she was unconscious. But the neighbors, the church, the whole village looked after the whole family. They provided meals, they gave respite, they gave care, they provided aloe vera plants because aloe vera wasn't really available and your skin was flawless. And it seems to me that it's more than simply the official decision makers or the family or the doctors. There's a community response that can be monumental.
Thank you very much for that comment. I don't think there's anything I could add to it. If we are a community, and we mean to be, then each of us is suffering and sick with the other, and that's what we're going to have to do. Thank you.
I was just wondering if you could comment a little bit further on the law concerning, I don't know, organ transplants between children. Does that include like bone marrow transplants? Or I don't know exactly what you mean by that.
Okay, with great deference to the lawyers in the room, and please asking you to correct, I'll take a shot at that. There is what's called the Human Tissue Gift Act, and it is common across the country and very similar to the act in the United States. And under the Human Tissue Gift Act, if we're talking about a non-replaceable, non-regenerable organ, then for those who are under the age of majority, which is a different age in different provinces, those children may not donate non-regenerable organ. They may donate blood, they may donate bone marrow, that kind of thing, but not a kidney particularly. And of course, any that's a single organ which would cause death, they can't do. So the thinking behind that in Canada, as I understand it, is that children should never be harmed. We may not be able to benefit them, but we should never cause them direct harm. In the United States, however, in court decisions, it has been allowed that a child can be a donor of a kidney. And the argument has been an interesting one. One argument has been that a child would suffer if it weren't a donor, because when the child grew up, the child would realize that the other one had died because the first one hadn't been generous. The second argument would be that the child would benefit from being a donor because that child would realize the child had done something good and therefore expand in a psychological way that it couldn't. But by and large, the sense is that we protect children and that we don't put them at risk for other people. So while blood transfusion would not be an ordinary thing, it could be done. My impression, and it's only that, would be that that would have to be heard in some sense by someone else. I wouldn't say a court, but I think that piece depends on the province. But the general business would be that yes, bone marrow, yes, blood, no kidney. Yes?
Well, the very first questioner touching upon the situation where the general practitioner used to perhaps make a decision, life and death decision based upon his knowledge of the family. And then the speaker who was suggesting that the community was able to rally around and help the family go through the death of a child. It seems to me to touch upon something that I've been wrestling with during your talk, and that is that perhaps the medical technology has, in its ability to save life and play God, has outstripped our human ability to deal with those issues. And it seems that the community was able to rally around the natural phenomena of a child dying more readily than a family can accept perhaps living with a child that's being kept artificially alive and presenting family problems that may be devastating through years of hardship. Could you comment on that, please?
I think, again, there are a number of things to say. I think, again, I want to just be on record here as saying that I'm not here to doctor bash. And I don't think anybody else is, but I just want to make that clear. I think one of the problems for physicians today is this whole notion of patient rights and autonomy. Autonomy has become a tyranny for the physicians as well. And they are very concerned that if they don't do what could be done, they might be accused of falling below the standard of practice. They might be accused of abusing and neglecting and so on. So it's not just we want to live at any cost. It's because of this litigation which is in the background and this concern about parents' rights and parents' responsibilities. But it does seem to me that in terms of the notion of keeping a child alive, as you're saying, there are many things that we can do as adults where we can say, no, thank you, that's enough if we're conscious and competent and able to do that, that haven't yet been clarified in our thinking about children. For example, a child who's 12, 13 may be able to make the child's own decision, and we haven't thought about it. I wasn't dealing with that group of children just now. So we may be going to the point where children will have to make some of those decisions themselves. But I certainly agree with your first comment, and that is that the advances in science and medical technology, if they haven't outstripped our ability, and I hope they haven't, because if they have, then we're into a very inhuman situation. We're going to have to keep trying. But if they haven't, they've certainly presented all kinds of difficult choices. So before, one didn't have the antibiotics to treat the pneumonia. There wasn't much you could do. There wasn't much choice about it. And therefore, it was easier to say, well, let this child die. But now we have it, and we have 2 or 3 other complications, and we have to say, shall we go on with this one, which implies this and this and this? So I agree that it's a much more complicated thing, but I think it's complicated further by the notion of the courts and law, and complicated by the physician's concern, not for perfection, but just I don't want to let these parents down. I don't want to do less than I could have done. How can I do it? And after all, physicians may not see the side of my family that I see, that this is causing this, this, and this. So maybe what we're after is more communication on both sides. I don't know. But I agree that it's gotten extremely difficult between, what shall we say, what you might call doing everything you can do, and then counting on the community to support you when that fails.
Parents in trying to reach the proper health care for the children have to rely on the physicians. But who makes the decision when the physicians cannot make the decision on what would be best for the child? Like, I think usually it would fall on the parents, but with the parents' limited education as to the medical aspects involved, and when the medical profession can't agree, who can make the decision instead?
Right, I think that's, an extremely difficult. What options do we have? It may be that physicians will have to act paternally, which of course is a bad word, paternalistically, which is a bad word these days. That's why autonomy, again, is a tyrant, saying you've got to choose, you've got to do that. Physicians have been, what shall we say, repudiated for making decisions for patients. They've been told, stay away, this is our thing. And yet they're expected to make decisions when parents can't do that. So one of the things that physicians have to do is to assess whether the parents are competent to make those decisions. And while they may appear to be competent, they may not be in terms of anxiety or ability to sort through reasons and facts and so on. And physicians then will have to do that. If physicians themselves can't make decisions, and of course that's one of the problems, that medicine is not certainty. There isn't that kind of certainty. We all think there is, but there isn't. It's a best estimate of what, in fact, is going to happen in a week's time, in 2 weeks' time, much less 10 years' time. Strictly speaking, they don't know any better than anyone else. They have a better idea of statistics, but not of this child. So they are forced to make some of these guesstimates to the best of their ability. They do have, indeed, they have a fine system of education so that there are always those who are senior and mentors. But the fact of the matter is they'll have to rely on colleagues if they don't make the decision and the parents don't make the decision, and we don't want the courts to make the decision. So what we're going to have to do is to find a way to see that this gets done and to bring together all the people to make the best possible decision, which may not be the best decision, but it's the best we could do at this time, which in ethics and everyday life in choosing, you're not expected to make the best, but you're expected to make the best possible. Yeah. Could I repeat what I think I heard you say? Who makes the decision about a foster child? I think a great deal of that is going to depend on the arrangements which were made when the child was placed with that family. speak just a little bit about Ontario. It will depend on whether, in fact, that's a temporary kind of placement or a long-term placement. It'll depend on whether the parents have been given, that is, the foster parents have been given that authority, or the other parents are retaining it, or whether it's in the hands of a legal guardian. I think what I'd suggest, because I don't want to mislead you, is that perhaps you'd identify the lady who spoke earlier, catch her and ask her that question, because I'm not totally sure of the state of that in Nova Scotia. It certainly could get very complicated indeed, and we have had, for example, foster parents. There's a very well-known case of a child called Philip Becker in the United States, where the foster parents wanted a certain kind of treatment which they said would save this child's life, and the child's own parents, with whom the child was not living, were refusing to give permission. So it can get to be a very complicated affair, and I'm sorry, I'm not sure that I'd give you the right answer. I don't want to mislead you.
You've talked of the legal aspect of the parents having autonomy for a child, and a lot of people have asked questions concerning the courts and when there's time to allow for mediation. What happens when there's an emergency situation or urgent medication that is needed? Does the doctor have the right to overrule the autonomy if the doctor feels that the parent is in a state where they're not autonomous anymore, whether they're in a state of shock or panic, or doesn't have time to be briefed on the medical aspects? Does the doctor have the right to make a decision in terms of emergency medicine?
Again, somebody here from the law can correct the comment, but I think the basic thing that we expect of physicians in the case of an emergency, which where I am is defined as the loss of life, limb, or vital organ, we expect the physician to act if there's nobody else there to make that decision. If there's somebody there who's able to make the decision and there's time to have it done, then obviously we're going to get the permission. If the person who is there is not competent, that doesn't count as a decision. That's just a facade. So the physician will do that. But now, bear in mind, when physicians do that, patients are quite likely to turn around and sue. And we already have a rather famous case on appeal in Ontario on precisely that kind of matter, where physicians acted in what they thought was a life-preserving, saving manner, saved a life, and the person said, "No way, I'll sue you." So it's very, very difficult. I think it's hard to say, physicians should do this, because always at the back is the question of the law, and behind that is the question of discipline from their peers. You didn't do that according to the regular way to do it, you'll be disciplined. It's an extremely difficult, and at the same time, parents saying, we want more information, spend more time with us, and at the same time, the government's cutting down the resources, saying 2 of you now instead of 3, and we'll add a few more beds to that unit anyway. So, it's an extremely hard thing to do, and unless we put the whole thing together in context, it's easy to say, well, the parents were negligent, the doctor didn't pay attention, whatever. It's a very complicated problem.
So with all this gray area, there's no definite right or wrong. Can anybody in the medical profession, the ethics group, is there a task force, and do they have any ideas how you could get it to be a definite decision? It seems so gray. Like in all the cases that you gave us, like you said, for the best interest, but everybody's idea of best interest is different, and every case was different, and it just seems there's nothing to grasp.
And I think, that's the reason I chose the cases, because we say so simply, best interest of the student. This course is in the best interest of the student. But now we have to say, well, what's that mean? Best interest of the student. And that's what philosophers do, and that's why they get in trouble, basically, because they take something that's fairly obvious and say it isn't all that obvious. But the question that you're asking is, how can physicians come to make that kind of judgment? And let's be very clear. First of all, the physicians of this country have a code of ethics. A code of ethics isn't going to help you to make every decision. It's going to give you a few guidelines across the way, and so that's one way to do it. The second is that they do have a body of peers, and they're very carefully regulated in terms of their fellowship, meaning their specialty practice, so they have to conform to the standards of the fellowship. More than that, within the Royal College of Physicians and Surgeons and the Canadian Medical Association, there are now ethics groups, if you want to call them that, ethics committees, and they're very concerned looking at very particular kinds of questions. For example, they'd be looking very closely at the question of What are we going to do when maternal rights and fetal rights are in conflict would be an example of that. So that's going on. Within medical education itself, there are enormous strides, being made on the campus here at Dalhousie, enormous strides to help younger students as physicians to think about the ethical problems that are coming up. It would be very difficult to say this is going to be right and you have to do it every time, because we know that there are going to be exceptions, and medicine is like that. There isn't any certainty. It would be very wrong to leave them without any kind of guidance or even thinking about it until, whoops, here's a case where I don't know what to do. So there is an attempt these days to include ethics education within medical education. In my own hospital, there are attempts to establish bioethics committees in various hospitals, not to make decisions, but to be there in terms of education, consultation. There are people who work as so-called clinical ethicists, which is what I do, to be available for consultation for those who want to talk about it. But I'm not there to say this is the right thing to do and you better do it. It really is a matter of parents and physicians coming together to do. My concern is that while we might do it individually very well, as the resources shrink, we're going to have to come to some other kind of mechanism. We don't want to go to the courts. We don't want to just leave it. We have to find some social agreement as to how it's going to happen.
I guess that as we reflect on this very important topic, we arrive at a barrel full of questions, really. And it seems fairly obvious that this issue affects us, at least some of us, very personally, or will at some point in our lives affect us very personally. I think we are looking forward to pursuing this subject with you, Dr. Lynch. On behalf of the audience this evening, the University and the Sisters of Charity in particular, I'd like to express our gratitude for this very thought-provoking presentation. Thank you. I'd like to remind everyone before we break up that the lectures continue tomorrow morning at 10 o'clock in the same place, and also tomorrow afternoon at 2 o'clock. Dr. Lynch will pursue this topic, actually, in two other areas. The morning lecture is entitled Healthcare Decision-Making for Others in the area of mental handicaps and marginalization. The afternoon lecture deals with elder ethics decision-making in that field. In spite of the fact that I've said that we are in competition with the Blue Jays precisely at this moment, I would guess, I would like to invite any and all of you, if you wish, to come and meet Dr. Lynch personally and either pursue the subject or simply have coffee and conversation with us. This will take place in the faculty lounge. If you come out this door here on the 4th floor, it's room 405. Thank you very much, and we'll see you again tomorrow.